Another IEMT Q&A with me, Andy Austin. Okay, now the first question I've been sent through, and this takes a bit of explaining actually to make sense of the question. And it's about the thing that when people say they get a headache, they feel sick, they get dizzy, their eyes feel funny, when you start them to move their eyes. When I teach on the course, what I say is treat that as the three-stage abreaction. The question has come in, what is the difference between a person who genuinely feels sick, genuinely has a headache, generally has got an eye problem as a result of you moving their eyes, pointing your finger, and a person who's doing stage 1 of a three-stage abreaction? It's simple. If when you start to go, okay, and how strong is that, or how vivid is that memory now? Look at my finger and start moving their eyes. The moment you do that, you start to see them going, oh, I don't like it. Ah! And then they start doing all sorts of physiological stuff, and you've not done anything yet. In fact, before you've even started the process, they have regarded the whole thing with some suspicion, some kind of resistance, some kind of, they're not happy and they need you to change what you're doing. That gives you a good clue as to what's going on. Three-stage abreaction. If you're doing it like this, and you're going and going and going, and then time passes, and 20 minutes later you're still going, and the person says, I think I feel sick now. Okay, they probably feel sick. If you have done the eye movements for more than 20 seconds, and you're creating a state of nausea, headache, dizziness, whatever else, that's you. That's not them abreacting. If they start complaining before you've actually really done very much at all, then that's probably them abreacting. If in doubt, err on the side of caution, err on the side of safety, and do something else. With experience, you'll start to know the difference between the two. So when you start doing this new for the first time, err on the side of caution. Don't assume everything is three-stage abreaction, unless it's really obvious to you. With experience, it becomes a lot easier. When we put out the member survey, I think it was last year, maybe the year before, the most common side effect people reported was that of nausea, dizziness, and headache as a result of the eye movements. When I started asking people, how long are you doing the eye movements for? We keep going until the SUD scale is down to 0. I don't teach that. I don't think I ever did. 20 to 40 seconds of eye movements is all that you need to do. You don't have to keep going and keep going. I must get a result because I did an NLP course once and I got to get a result. There must be a result. We've got to get it to 0. This is IEMT. We have different presuppositions. We have different procedures, and you don't have to get a result in the first session to prove how brilliant you are. You can relax a little bit. Remember, there's no great rush. I don't quite understand this whole thing in therapy, especially out of the alphabet therapies that have spilled out of the NLP era. There's this need to have everything fixed in the fastest possible time. Now, for some content creators and developers, that was a good marketing ploy, especially when they're coming from a backdrop of psychoanalytical-based therapy, which is basically 30 years to the rest of your life in therapy, when nothing much happens. So it's a good marketing ploy for those guys to say, well, we can do it in a single session. We can do it in 20 minutes. Some phobias can be done in just a couple of minutes. It's true, they can be. But we don't have to be doing that as this emphasis on how we're getting change in how we approach our clients. When people have been very unwell for a very long time and had a lot of problems for a very long time, and they've suffered immeasurably, when we offer them a cure that would just take 30 seconds, we might be insulting them quite measurably. So there's no great rush. I like to slow things down a little bit, actually. The kind of sessions that I will do may well be I do a 10-minute session today, and then next week do a 20-minute session, and then leave them for 2 weeks, do another 10-minute session. Sometimes I will do 2-hour-long sessions. It varies. I don't have a guideline to say when I would do it like this, when I would do it like that. It mostly comes down to experience. As Frank Farrelly said, the first 10,000 clients are the hardest. So if you're getting lots of people saying they have headaches, dizziness, nausea, all that kind of stuff through the work that you're doing, I don't get that, by the way. I need to just let you know, I may get that once in a while. It's not something I recognize to be a particularly common problem when I'm doing eye movement work with people. So if you're getting that, I would urge you to have a look. What is it you're actually doing? Film yourself. upload it somewhere private, send me the link, let me have a look. Some of the other trainers can have a look for you as well. The chances are you're either going way too fast, quick, move the eyes, we must do it quickly, or you're going on for too long or longer than is necessary. If you're getting lots of abreaction type things happening, lots of physiological symptoms reported, then you may want to reevaluate what you're doing. So that's the first question. Let's look what we got next. Next question, my all-time favorite. How does IEMT differ from EMDR? My standard answer, they're exactly the same. There's no difference whatsoever. In exactly the same way that NLP is identical to Freudian psychoanalysis. They both use words, and EMDR and IEMT both use eye movements. Apart from that, they're identical. I'm hoping, I've been trying for a long time to get an EMDR trainer to write me a review of the difference between IEMT and EMDR. It is on the website, by the way. It's been up there for years. It's just that no one seems to look at it. It's on the website, so do have a look at the difference. Now, if you are an EMDR trainer and you look at that and go, that's not a description of EMDR, that doesn't fit, that's not what I understand EMDR to be, you're wrong, Austin. I didn't write it. An EMDR trainer wrote it a number of years ago. And ever since it's been on there, when EMDR trainers have a look at the description of EMDR, they seem to be outraged that that is EMDR, because it's not that. Well, if that's the case, if you're one of those people, do please get in contact. I would love you to review the IEMT material and rewrite that page and give us a review of how they are different. Now, if I'm completely serious, they are not the same at all. There is no similarity between them apart from the fact they use eye movements. That's just the modality by which change is affected. EMDR is not eye movements. EMDR is the application of eye movements to specific stuff in specific ways. IEMT is not eye movements. It is the application of eye movements into specific stuff in specific ways. So they're not the same thing, and they have comparability in terms of what does eye movement achieve. It is the application and the model of IEMT that is so profoundly different. For example, you're not going to find the PTSD model that we have of the linchpin in EMDR. You're not going to find the 5 patterns of chronicity. You're not going to find any of the exercises, in fact, any of them. In fact, you won't find any aspect of IEMT in EMDR. You will find a little bit of EMDR in IEMT, because we use eye movements. That's about it. Now, recently we've had a bit of an issue where Michael Carroll, posting as John Grinder, the real John Grinder, is claiming that EMDR was ripped off from John Grinder's work, and IEMT is ripped off from EMDR. Therefore, IEMT is just plagiarism of John Grinder. The most absurd thing. I've written to John to say to him, okay, if that's the case, given your description of what you said you did with Francine Shapiro, which is just a little paragraph, and EMDR training is about 7 days long, I suspect EMDR training is a lot more than just the bit that John Grinder said. EMDR is not the precursor for IEMT. It's not. There's threads, there's elements, but it's not the same thing. Where within the IEMT model am I doing anything that is described from the information John Grinder allegedly gave to Francine Shapiro inspiring EMDR? I've asked the question. I'm asking the question publicly here. If anyone would like to examine, anyone from the new code world of new code NLP would like to examine IEMT, have a look. I am more than happy to make the material available to you in order for you to find where John Grinder's work resides within the model. Good luck. Anyway, you know what, so get in touch. I'm easily contactable. Okay, next question. I love this one. Has anyone ever worked with a person who's 70 years old or older? My focus is on those with low ability to understand what it is I want from them. Any suggestions on how to approach? Now, what I love about this, I know exactly what the question means and the context in which it's asked, but of course immediately the older members of the IEMT world got offended by that because I'm not low ability and I'm over 70. That's not what it's about. Now, I've worked a lot with the elderly, mostly when I was a nurse. And there are a lot of people, as they get older, they develop a lot of problems. And to enhance the problems that they have, the ability for comprehension, the ability to hear, and sometimes the ability to see can be impaired. So giving direct requesting information from the person, giving instruction and command to the person can be seriously impaired by the barriers to communication, but also barriers to comprehension by the client that we have. Here was my all-time favorite scenario that I ever worked with. And this is going back quite a few years now. And this was a person who came to see me with phantom limb pain. And it's an area that I specialize in, and I get very good results with phantom limb pain. Not necessarily using IEMT, although I have used that when the amputation was traumatic, and there's trauma associated with the pain. So I opened the front door. I was working from home at the time, and I'm on the doorstep is a very elderly-looking couple, where the lady is holding up the husband, who looks like he's about to drop dead, to be honest, any moment. Now, all they need to do is step over the little door frame bit, the little thing at the bottom of your front door, to come into my office and then sit down on the sofa. That took about 20 minutes. Just getting him to be able to take that step over the thing that's 2 inches high of the door frame was quite challenging, and then maneuvering him through the little bit of the corridor into the office and then into the sofa, challenging. Now, he is deaf as they come. This is what the session looked like. Okay, so can you remember a time when... What did he say? Looks to wife. He said, can you remember a time when? A time about what? And I was having this shouting conversation through his wife to him, where she didn't really... it was hopeless. It was a nightmare. And so now we have a problem, because he has a treatable problem, but I'm not in a position to be able to treat it effectively because of the limitations upon communication that is offered by the situation. So now herein lies a difficulty. And for me, that is a client I can't work with using that modality, using the mirror box, which is what I was hoping to be using, or using the IEMT processes that at the time I was really still developing. So there's an inbuilt limitation that comes with the client. From the NLP world, there is this notion that there is no such thing as a resistant client, there is only a resistant therapist. And that essentially, it doesn't matter who the client is, what the problem is the client presents, there's always a way to help them. Everything has a happy ending. Everything can be fixed. We are magicians. We are gods. We command the forces of the universe. We can cure cancer. We can make people immortal. No, we can't. None of those things are true. It's a good marketing ploy, and I want people to understand that concept. What gets taught from the stage, what gets sold from the stage, what gets preached on people's YouTube videos, even on mine, and on people's web pages, doesn't necessarily equate to reality. Something that's worth bearing in mind. There are so many therapists and trainers who have no experience. They have no clinical experience whatsoever, and they have no clinical training. And I've known trainers who've never seen a client in their life. Really. They've gone and done the practitioner course, master practitioner course, signed up for the trainer's training for whatever it is they're training in, and then teach it straight away. Because they don't want to work, they want to be a trainer. They've never had any clinical experience, and yet they have a theoretical understanding of what is possible for absolutely every client that you can... Be aware that some people do not operate from a position of reality. They operate from a position of fantasy and projection and wishful thinking. While I'm on my little rant here is something that is worth knowing. I have watched certain NLP trainers and other therapists. I have watched some of their videos where they're making some pretty impressive claims for some of the conditions they have worked with. Not fixed, not cured. I work with cancer patients a lot. I specialize in physical diseases. Really? Will we ever see a video? Will we ever see evidence? Will we ever see results? No, we won't. I won't name who this person is, but I know some of you watching this will know exactly what I'm referring to. I have watched a certain big name trainer make claims, pretty big claims, for a patient who they worked with on the stage who had a miraculous cure. And they've been telling this story for years. That's one of my patients. I sent them. And I can tell you for a fact, that patient did not recover and was no better off whatsoever. In fact, he was not very happy, it would be fair to say. Now, I have watched that same trainer spin that story yet again in the last few weeks. And I bet you if anyone said to that trainer, that patient, what's his name? Do you remember his name? I bet he doesn't even know his name. I bet he never even knew his name. I do, because I sent him. Now, you are being lied to by so many therapists and healers, as they're all calling themselves now. Everyone's a bloody healer these days. You're being lied to constantly. And there seems to be this need, this peer pressure to make grandiose claims. I have IEMT practitioners doing the same thing. The miracles that some practitioners are claiming, I've never even achieved myself, and I'm just constantly amazed. Really? How do you manage to do that then? How come your results are so unbelievably good and so unbelievably high? I suspect they're good because there's no follow-up. You see, if I believe I've cured somebody and I never follow up, then my story in my head is, I've cured them. But I know when you follow people up months and years later, you may well get a very different picture. So be aware of this, please, that you're not necessarily going to cure everything and everybody. So back to how do I work with the elderly who are sensory impaired, communication impaired, and everything else? Generally, you may want to consider referral for people who have different modalities of working with that problem. Medication is always an option. Other forms of medical treatment are worth considering. In fact, really, you should be considering those first, and that what we do is secondary to that. I don't think of any of the work that I do as alternative therapy, an alternative to medical practice, as so many therapists do. I see myself as complementary to medical practice. It's not unusual for me to refer people back to GP, refer people back to the clinic that they've come from. I often do communicate with doctors around people I'm working with, because I want certain things I want to be checked out. Because not everything that manifests psychologically and emotionally is going to be psychological and emotional. They may well be physiological underlying things that need to be looked at. So when you've got somebody that basically they present a difficulty, they're too elderly, they're too confused, they're too infirm, they're too impaired with communication, you may want to consider other options. Right, next up we have, where did the notion of eye-accessing cues come from? Bandler and Grinder, I guess, but specifically that a particular direction is about accessing a particular sensory. Did they test this and report it in the paper, or get it from another paper, that sort of thing? I've got to be honest, I have absolutely no idea whatsoever. I have a little guess. I'm going to guess it's likely to be a Bandlerism, only because he's the one who's talked about it the most. I'm not that familiar with Grinder's work, but I've never heard Grinder refer to those things. One of the problems about eye-accessing cues is they don't really stand up to scrutiny in the way that people claim them. The way that I've seen Dilts write about it in his books, the way I've heard Bandler refer to them in his talks, his trainings, don't match the claims that are investigated by psychology. Because there's so many papers written about accessing cues that basically say they do not stand up to scrutiny, therefore NLP is invalid. No, well, eye-accessing cues is not the totality of NLP, it's just a very small feature within NLP. So the invalidation scientifically of eye-accessing cues does not invalidate anything apart from saying eye-accessing cues as claimed by the researchers investigating. But what I see written on those papers doesn't actually match what I have read from Dilts, what I have heard from Bandler. They're not the same things. Essentially, it comes down to calibration. And so people do move their eyes in specific ways, and it does match up for some people some of the time with their sensory predication, the visual, auditory, kinesthetic, and so on. So it's a calibration process. Now, what I did with the accessing cues really came through working in neurosurgery. Because when you look at that chart that is standard to most NLP training manuals and textbooks, The one thing that should stand out to everybody is it's two-dimensional. It's not in 3 dimensions. When I took that into the neurosurgical department that I worked in back in the day, and I showed that to one of the surgeons, that was the first thing he said. It was like, but that's two-dimensional. We don't examine eyes 3-dimensionally. And so there's a calibration process here. And I wonder if Eric Robbie's work with submodality eye-accessing cues may have a feature in here as well. You see, when I look down to the left, we assume left is a generic direction. But actually looking down completely to the left or looking down at a more shallower angle is not the same thing. But also the distance by which we focus is not the same thing. But also we have an arc of about 90, well, it is 90 degrees within that quadrant. So I could be looking down left here, or down left here, down left here, down left here, with different ranges, and so on with all the access, all the quadrants. There's a lot more to eye accessing cues than people realize. My frustration is with NLP practitioners, that's it. They are just repeating back the stuff from the manual. They're repeating back what they remember being told, which may not necessarily be what they were told. And they then teach that to somebody else, and the same distortion, deletion, generalization process occurs. And I think it's problematic. So where did eye accessing cues come from? I've absolutely no idea. Hopefully, comment section below, somebody else can actually fill that little gap in. Never been interested to look, to be honest. My stuff is more in the application of what we can do with the work. Right, next question. I would love to see a recorded IEMT session with you. Are there any available on the net? Yes, there are actually. I think I've got just the one. There was one that I started to become increasingly uncomfortable with, and so I took that off. Yeah, it was. I wasn't on my best day. It wasn't a good day for me that day. On the IEMT website, so integraleyemovementtherapy.com, you can get the practitioner videos. One of the bonuses on there is a demonstration session with a member of the public who did not know what she was coming to. The setup was this. I'd booked a room just around the corner from where I live. I'd advertised for people to come, and I had a number of people booked that day. During that day, this lady turns up, and she has no concept of what she's coming to. She had no idea at all. It was a friend had just suggested that she comes along. Now, I didn't know that. I thought she knew what she was coming for. So when you watch the session, you'll see there's a lot of confusion. She has no concept of eye movement. She has no concept of who I am, and no concept of IEMT at all. It's a fantastic session because I'm working reflexively with everything that she's doing and saying because there's no presenting problem. It's on the Integral Eye Movement Therapy. If you click on, it's either videos or shop. I'll put a link on the video here. You can access that there. There's another one floating around somewhere. I think it's in the members section of the website. So it's for the association members. And it's the lady with depression. And this was a person who was, horrifically depressed. I won't give you the background to what you have on the session, but essentially she has what we call a smiling depression. So very attractive, well presented on the outside, very, very unhappy and miserable on the inside. So it's a smiling depression. And they're on the membership site, sorry, on the association membership pages, that video is on there along with the case study write-up. So it's the demo case study for trainees to use. So there's 2 on there. At some point, I'll get some more recorded so you can see what a session with me looks like. For those asking, I don't do them online. I don't do IEMT online. I don't do IEMT training online either. I only do these things on one-to-one live. There are trainers and other people who do things remotely. I prefer not to. It just doesn't work for me. It's not really the way I think to do this work. I would also like to know if I can use IEMT to withdraw someone from his negative habits like smoking or different obsessive compulsive disorders, and if yes, in what way? That's such a vague question, I don't really know how to answer it. With withdrawal, that would imply addiction stuff. I don't work with addicts. I don't work with smokers, I don't work with drinkers, I don't work with drug users at all, simply because I don't have the patience. And most of all, I don't have the interest, to be honest. I just think, just stop buying the stuff. Just stop buying it and stop putting it in your body, and therefore the problem goes away. that's how I think, and that's how I have dealt with those things in my life in the past. I used to smoke quite a lot, drink quite a lot, just stop doing it. And life gets a lot easier. But I'm aware most people don't think like that or have the same mindset that I have. So I pass that to other people who can be a bit more empathic with those people with those difficulties. So I can't speak from any position of experience whatsoever. Comment section below, if you have experience in working with withdrawal, what are your results? I don't want, well, it should work. No, only if you've got experience. Speak from personal experience where you have followed up and reviewed the quality of your work. As for OCD, OCD is a problem diagnostic. Because OCD is a neurobiological disorder, and it's a very real disorder. It's become like autistic tendencies, Asperger on the spectrum. I'm slightly OCD, I'm slightly attention deficit. It's become a label, like PTSD actually, that gets applied to things that it's not. Like the majority of people with PTSD, or say they have PTSD, they have nothing of the sort. Nothing of the sort. It's just that that sounds like a reasonable label for them to give themselves, and they don't have that. It's a clinical thing. The majority of people with OCD, or say they have OCD, they don't have it either. If you see a real OCD patient, you will understand the difference. There is a significant difference between people who are a bit neurotic and people who have OCD. OCD is problematic from a treatment point of view, and I have seen so many NLPers especially claim that this is not the case. I don't believe them. I simply don't believe them. OCD has the lowest placebo response of any disorder that I'm aware of. This means that it doesn't change. Cancer has placebo response, but OCD has a lower placebo response than that. This is a problem. It's neurobiological. I'm not convinced that IEMT, NLP, hypnotherapy at all will cure OCD. I am convinced the majority of therapists who claim to cure OCD using those processes, they're not treating OCD. They're treating other problems that the patient is calling OCD, and it's not the same thing. If you have something that you can demonstrate that what I've just said here is incorrect, and there is a way of working with those people effectively, then I want to hear from you, and I want to know how you do it. The best treatment methods I'm aware of are those fairly intensive and actually quite unpleasant at times, systematic desensitization type work, usually in a residential setting, by clinical experts. We're talking psychiatrists, psychologists, and neurologists. They tend to get the better results. It's labor intensive, it's time consuming, it's very expensive to do. They seem to be the only people I'm aware of that get genuine results. I'm not convinced by the lay therapist claims that I see online. As I say, but I'm willing to be proved wrong, and I'd be delighted to be proved wrong. Okay, now this one is from Shawn. I'm going to give his name because I think this is one of the best questions I have seen in a long time, and I'm not even going to answer it because I think Shawn already has the answer, and I just wish I'd thought of this. So I'll read you the full thing. And again, this is for the comment section. I'm not going to attempt to explain this or answer it. A fellow hypnotist just asked me about IEMT, and I jokingly said, think of a memory and wiggle your eyes. Then I randomly added that it's similar to the fast phobia cure, where you're looking at a memory but your eyes are moving back and forth. Which got me thinking, is it? Because the submodality changes to the memory in IEMT, remember those things, it gets further away and so forth. Because the submodality changes in the memory in IEMT happens from moving your eyes in different directions. And in the fast phobia cure, you're controlling the memory to go backwards and forwards, and you're changing submodalities of it directly, as in, you're doing the dissociation back to the cinema screen and so forth. In both, it seems it's the movement that the eyes process that changes the encoding of the memory. Either watching the memory going forward, backwards, speed up, or your eyes doing the movement itself. What are your thoughts? Yeah, I'm going to leave that one to the comment section. I will even paste this question into the description so you can actually see the question in full. I will be interested in what other people think of this. Next question. Are there any changes, updates, or exceptions to the contraindications for including or excluding an individual for IEMT? In the membership section, there's the members manual, and in there is the list of contraindications. I don't have anything to add to it or take away at this stage. Now, these contraindications are based on common sense rather than clinical data. The manual's on there. I'm not going to go through the list on this video. You can have a look on the members manual. And for the practitioners who've never looked at it, do look at it. The only thing I'm going to add to this is more and more people are now working remotely, doing Skype work with clients. And it doesn't really matter whether you're doing IEMT or any of the other models at all, but more people are working remotely. I'm going to urge you to make one addition to the information you collect from your clients pre-session. Where are they phoning you or calling in from? Basically, where are they at the point you're working with them? The reason I say this is because statistically, if you work with enough people, you're going to have a medical emergency happen at some point. Individually, it's going to be a very low risk thing that's ever going to happen. But with more and more people working remotely, statistically, it's more likely to happen. Just picture the following scenario. The person on the other end of this call goes blue with a heart attack, or they just go blue and lose consciousness. And now what are you going to do? You don't know where they are. You may have their home address, but is that where they're calling you from? You need to know where that person is located when you're working with them, because otherwise you're going to be in a very difficult position. What are you going to do about this? What do you do in that scenario? So I would urge people to get clarification on where is the person you're talking to, where are they at that time. I've only had, in all the years I've been doing therapy work, I'm just trying to think now, I can think of 3 emergencies that I've dealt with. 4, I had another one. 3 of them were psychiatric emergencies that actually involved having to get out the crisis team for those people. And one of them was a medical emergency of some neurological description. I'll spare you the story. So it's worth knowing, if something went wrong, what are you going to do? That's your number one thing. For contraindications, if the person is fit and healthy and able to follow instructions, then mostly they're going to be fine. But do please refer to the members manual around things like eye condition, glaucoma, stuff like that. That is quite important. I don't think the eye movement work is going to necessarily make a condition worse or give someone a negative condition. I don't think that's likely to happen at all. However, the issue is that of attribution. Because doing this with people is a weird thing, and we have to be realistic, this is not research-based, it's just something I've made up, it's something that other people are trained in, it's become a therapy, but now think about in a courtroom where you've got cynical barristers cross-examining you and a jury who know nothing of therapeutic approaches, because someone has either crashed their car on the way home, or they've got a sty in their eye, or something's gone wrong a week, 6 weeks, a year later, and they go, yeah, it was the eye movements, that's what did it, it was the eye movements. Now an attribution has been made. It may not have anything to do with it at all, but once the attribution is made, how are you going to argue your way out of, well, I knew he had glaucoma at the time, but I thought it would be safe. You can see how this would look. So this is where you have to actually think in terms of what you're doing, is how would this look in a courtroom where you have disinterested parties who have no vested interest in your work, and a cross-examining barrister who knows how to humiliate you and make you look silly. So those are the things really you have in your mind when working with an individual. One of the questions that comes up periodically is, I've got a person who has a history of epilepsy, they've not fitted for 20 years. Is IEMT safe? Well, I don't know. How would I know? I don't know whether it's safe for that individual. Let's put in the missing bit. Is it safe for that individual? I have no way of knowing. The question is, do you think it's safe for you to work with an epileptic? If someone did have a seizure in your office, or heavens forbid, on the other end of your Skype call, do you know what to do about it? Now, personally, I do. I worked in accident and emergency, and then I worked in neurosurgery. So dealing with epileptic seizures in their varying forms was pretty much a day-to-day activity for me. So I'm very comfortable and confident in dealing with these things. The question is, are you? If you don't know how to deal with the potential consequence, you shouldn't be doing it in the first place. So my response to, is it safe to work with that person? If you need to ask me that question, you already know the answer. And so you have to be sensible about this. I don't know if that answered the question. I don't recall what it was now. Okay, so, oh yeah, contraindications. Right, let's move to the next one. A person who experiences anxiety by way of rapid negative self-talk can utilize Nick Kemp's internal tempo change exercise. If you don't know Nick's internal tempo thing, have a look. He's got a number of videos up on YouTube. Have a look at Nick Kemp's work. He's got some fantastic resources and techniques for dealing with anxiety. However, I've encountered a person who has rapid internal images, not dialogue, flashing in their mind. Would you utilize IEMT for those images by eliciting them one at a time? No. Okay, next question. To date, what's the most effective way to use IEMT remotely, via Zoom or Skype? I don't know, because I don't do it. Let me give you my reasoning as to why I don't do IEMT remotely. You don't know how big the screen is that the other person has got. The amount of people that dial in on their iPhone, for example. And you're doing this, but at the other end, they have a little window like this, or little movements. It's not going to work. And also, are you getting them to follow your finger like this, or are you just telling them, instructing them to move their eyes? I don't know how people are doing this. I can't pretend I'm entirely comfortable with people doing this via Skype or remotely. However, I'm yet to be shown any problems that have arisen from it. What I am aware of is that some of the courses that people have taught, they've been afflicted with technical difficulties and people's unfamiliarity with the technology and unfamiliarity of talking to camera. Not worried about that. That's more a meta thing to the actual IEMT work. But can we do remote work with eye movements? Can we do that safely via Skype? Can we do it effectively via Skype? I think time is going to tell. I think I should do a survey of people, actually find out, how are you doing this? Are you getting them? Are you moving your finger or instructing the person to move their eyes? Are you able to calibrate for the axis deviations? I think you might do for some people. It depends on how big your screen is, I guess, and whether they've got good lighting. The amount of clients I work with, I have to tell them to relocate themselves, because they sit themselves in front of a window, so the window's behind them, and what I see is them in silhouette. So I tell them to switch it around the other way. They don't like that thing because they got the wind light. Anyway, so it all depends on the setup. I don't know. I think time will tell whether remote working and what the best way to do remote working is. If, by the way, you've had any difficulties or problems arise from working remotely doing IEMT, do please let me know, because this is good data. People only ever give the success stories. I don't know why people don't give the things that go wrong. People cover up all the negative stuff, and it's like, what do you think? What are you doing? You're supposed to be a therapist. Okay, I would really like to use one of your videos, the passing the ball technique, as an inspiration to produce a set of coaching videos to help clients with anxiety. However, being relatively new to the business, I'm anxious that I will be contravening a code amongst therapists. Inspiration is all around us, and I have been brought up to be respectful to those who have the ideas. How much do you publicly credit each other with work in the field? How much referencing of source material do you do before something becomes your product? I don't want to tread on toes or muscle my way in, but just establish myself as a reputable therapist. Now there's a couple of metaphors to discuss. Right. It's a problem. This whole thing of intellectual property is hugely problematic, and most people who've come up with ideas and concepts and then make a living from those ideas and concepts are very precious about people copying it and then ripping it off. Everything I have ever produced has been ripped off and reproduced, and that person reproducing it usually is the person who came up with the idea. Amazingly, only after coming on one of my courses, they suddenly discover eye movements. I came up with that myself. It's a problem, because I know that some of the stuff that I have put out of mine was something somebody taught me years ago. I had forgotten that, and then in thinking about stuff, thought, wow, I've come up with that. and I didn't. Those who've done the metaphors of movement work will be familiar with my thing about the direction, distance, mode, and rate. I was convinced I had come up with that entirely myself. I hadn't. Charles Faulkner had sent it to me years before. I've still got the original email after he pointed it out to me. I was like, whoa, didn't know. So I know it's very easy to inadvertently reproduce ideas as your own if you've been taught things a long time ago. There is also the other problem, of course, is just because someone discovered it 20 years ago, wrote a paper, doesn't mean you read it and you can come up with that idea entirely independently yourself, because, you know, duplicate ideas are made up by duplicate people independently of each other. And then that can be problematic, because then you can be told, well, that you've copied that. No, I didn't. I did come up with that entirely myself. I've never heard of that person or read that paper. So that's a possibility too. The problem comes when people self-credit with somebody else's work. So it's blatant. And those who are familiar with my history of the metaphors work in the IEMT, you will know the people I have deliberately and publicly accused of plagiarism, where they have wholesale copied my manual, my material. They've even used my case studies and my jokes and my stories. They even reproduce those as their own. And I will publicly call them out on that behavior. So that's a pretty poor behavior, and it's endemic to personal development, with the level of narcissism that is rife within the field. Those narcissistic individuals are much more likely to guilt-free rip off other people's work. Now, the juggling ball exercise, that's not mine. I don't know where that came from, but that's been known pretty much since the late 60s. And there's lots of examples and variations of that online. I don't know where I got it from. It may well be something I came up with myself spontaneously. I probably didn't. It came from somewhere else, an idea, something somebody said to me once, and then I developed the process that I use based on that idea. Where it originated from, I don't know. So it's public domain. Just help yourself. It's not unreasonable to credit where you got something from if you know where it came from. So supposing it's a Gregory Bateson idea taught to you by Andrew T. Austin, you can say you could say that based on the original idea of Gregory Bateson as taught to me by Andrew T. Austin, or just credit Bateson. It's a tricky one. Go with what your conscience tells you. Don't be like one of these narcissistic individuals who just rips off everybody else's work and presents it as their own, renaming it or not, as the case may be for somebody I've dealt with recently. Been quite extraordinary. Just copied my website and kept the same name and put themselves as the creator, and even told everybody they taught it to me. Amazing. Absolutely amazing. So you can't endlessly credit every single idea that you teach. If you look at, say, the NLP model, Bandler and Grinder generically credit their influence, like the Milton Erickson, Virginia City. There's a generic accreditation of their work. They haven't gone through each individual piece, putting the accreditation for every single idea and concept. That would be nuts. So there's another thing you could do as well. You can give a generic accreditation, if that's even the right words to be using. Again, use the comment section below. I'd be interested if there's a proper protocol or form to follow. There must be. It's a common problem in academia of people accidentally plagiarizing or just deliberately, blatantly plagiarizing. Right, next question. Do you have experience successfully using IEMT with chronic developmental attachment trauma where there is no specific initiating event memory? I'm not entirely sure I understand the question. Who knows? I don't know. I'm lost for words here. Do you have experience successfully using IEMT with chronic developmental attachment trauma? I don't know what a developmental or attachment trauma is. If I think of it this way, a person comes to me, they're all messed up, they don't know why, and there's no memory attached. I'm going to do something else. Remember, IEMT is largely memory-based. We're using memory to access emotion. No, we're not. We're using emotions to access memory. But if a person is not able to access the memory, do something else. There are a million other methodologies that are all equally as effective in certain contexts. Generally, I will use IEMT for when the person's been messed up by life, but when a person is messing up life, I'm going to use the metaphors of movement approach. You also have things like core transformation, absolutely fantastic. Connie Ray's latest work, the wholeness process, absolutely fantastic. You've got clean language, which is a good recourse to fall back on. For me, that's a good thing to have a good thing to have in your toolkit. You've got all the NLP techniques and so on. There are so many different things you can do. I think there is a problem of therapists having a bias towards their preferred treatment modality and excluding all the others. As much as I deride tapping work, I will use it. There will be contexts where actually the ability of the individual to comprehend psychoeducation or the psychological processes I want to work with them, if their ability to comprehend that is not going to happen, it might well be that the most empowering thing I can get them to do is to think about something horrible and then do something else. It's nothing unreasonable to that. When people use the same technique on all problems, they're assuming that all problems are structured in the same way and will be amenable to their magic trick technique. And I think that's a very shoddy way of thinking, and it's very poor therapy. So with regards to the question of chronic developmental attachment trauma, I don't understand what that actually means, so I'm sorry, I can't answer that one. Maybe use the comment section to explain further. Next question. I'm interested in any observations, experiences, or generalizations about working with people beyond the eye movements with an internalized concept of you. So this is about the pronouns, the I, me, self, and you, and their location, age, and all the rest. Now, generally, you is going to be external. I, me, self, you. Some people have you internalized. You are part of me. You are my emotions. You are my heart. You are my everything. Sounds very romantic in the movies. Possibly a nightmare to live with a person like that. So when people have an internalized version of you, there is the issue is very much, in order for them to feel better, they have to change you. You needs to be changed if you is upset. Because your upset is my upset is your upset. And therein lies the issue. So it's a lack of boundary between self and other. I wonder where this fits in with narcissism. What we're going to see, if you are inside me, this is where the Professor Vaknin's work comes in very, very nicely. The narcissist doesn't see you as in the physical, real you. They see an avatar they have in their head, and they assume you are that avatar. So the relationship they're having isn't with you, the person. The relationship they have is with the avatar. Some of you have parents like this, and they do not know who you are. They think you're somebody else. And no matter how many times you try and explain yourself to them to justify it, and get them to understand, to get them to realize you're not the person they think you are, you have to start from scratch every single time. There is no continuity in day-to-day relationship. Your ongoing relationship with your parent or parents has to be built afresh every single time you see them. There's no continuity across time because they don't take in new data coming from you and build that into their representation and relationship of you, because you don't exist. The avatar of you is the correct one. And so that they have an internalized you. They may well appear to be a highly hypervigilant, hypersensitive, empathic individual to everybody else. To you, they're a nightmare. And that's simply because they have an internalized version of you. Some people have this in relationships. And I have known people, I can think of a very specific couple who may even be watching this actually, who when I used to live very, very close by to them and socialize in the days before I became a recluse, they both had this internalized version of the other. They were it was disgusting. Go down the pub, everywhere you go, they constantly got their tongues down each other's throats. They've been together for years, but they were so into each other. It was just horrific. It was awful. Don't invite them round. When we had movie night, don't ask them round, because they would just sit there the whole time tonguing each other. They lived together too. Now that relationship didn't last very long. And what was interesting to me was that when they split, how dramatically different their lives became. They didn't have a dramatic personality shift, but it was as if they had a personality shift, because suddenly a whole world opens up to them. And they have both gone on to be very successful, happy individuals, and successful in relationships. But when they were together, they both had an internalized version of the other. And it was like nothing was ever going to be enough. I don't know what the relationship is between what I saw with them being heavily, heavily into each other and the hyper-vigilant parent with whom you have to build a relationship afresh every single time you see them. You'll also notice that every time you do something they don't approve of, which is every time you are yourself, they are hypersensitive to that. They could be offended very quickly because you've deviated from the mental representation they have of you. So I think this is really the only representation I particularly have of internalized concept of you. I would recommend Sam Vaknin's YouTube channel. He has got hundreds and hundreds of videos talking about stuff. One of the best teachers I've come across on YouTube. So check that out. I'll put up a link somewhere on the video or in the comment section for people who are unfamiliar with his work. Whilst he talks mostly about narcissism, I would highly recommend you watch all of his videos. Even if narcissism doesn't appear to be an issue in your life, you will learn so much. You'll be very, very pleased that you spent the time studying his work. Okay, next question. After a case from a friend that I heard of, mother is a suspect for corona. Father got anxiety and deep depression as a result. What could we do with the father? No idea. Someone's replied to that. Anything. Yeah, anything. Who knows? Who knows? That's one of those, without knowing more data, without meeting the father and all the rest. Is he known for depression? Is he hijacking? See, this is quite a common issue. One party gets ill and the other person feels like, hang on, I'm the one who's supposed to get the attention, and there's a counter reaction to that. There's lots of things that go on in family dynamics around attention and control and power, and people playing off illness and depression and mood swings and all sorts of other things. Okay, last question on the list here. All right, this is a good one. So what are your thoughts on the theory that I, the pronoun I, is the current experience of the self, and me is the autobiographical part of the self, as per the work of various neuropsychologists? Also, what is your process for working with people who describe two or more I's at different ages? One may actually be described as older than their current age. All right, so this goes into the pronouns of I, me, self, and you, and how we elicit those in the identity work within IEMT. I've got to think about this one. So if I is the current experience of self, I don't recognize that as the thing. I see self as an expression of I. I is very much an internal, expressionless experience. And self is what is expressed publicly from that experience. So my public self, my private, I got an I that's very secret and private, and I express myself to you. Now, me is a receptacle, it's a container. Me receives you. So I express myself to you, and you fill me with hope. You leave me empty inside. You drain me. You bother me. You fill me with anger. You make me mad. So me is very much the receiver of you. I is very much communicated through self to you. And that's the dynamic that I see within the IEMT work. I need to read the actual paper about the autobiographical part. I'm not particularly familiar with that. Now, when people have multiple I's, multiple selves, multiple me's, that's really common. We have multiple identities, multiple faces, multiple things that change according to context. So the person I'm being right now talking to camera is going to be very, very different to the person I'll be having Sunday dinner with my parents. Very different person that when I'm in the bath, very different than when I'm on holiday. We have different aspects of identity, and sometimes we have a completely different identity and different persona and largely different personality across context. It's sometimes when we don't have those shifts across context we get into trouble. Imagine me as a nurse who was like I am here. didn't fit in, didn't really go very well. But is any of, when we shift identity, we shift persona, we shift personality, is any of those false? Are any of those false? Possibly they can be, but just because we change doesn't mean it is false. The issue comes down to how much are we pretending. So I can be a different person. I can be the professional when I'm in a hospital uniform. I can be very unprofessional when I'm in hospital uniform, and also when I'm out of uniform, and so on. Shifting those contexts doesn't necessarily mean any of those things are a lie, but I might be pretending. Just look at the narcissistic trainers and therapists and alphabet therapists you see on Facebook and on YouTube. Look for the ones with high levels of virtue signaling, very, very superficial engagement with knowledge and stuff, but they like to walk, they like to talk big talk, they like to talk about themselves, claim qualification, certification, grandiosity, and so forth. It's endemic to the therapy world. They're lying. And so they will have multiple I's that shift according to context, but they are wrong, they're incorrect, they're not genuine I's. Now, when we have a client who has, say, two I's, one of which is a lot older than themselves, one of which is a lot younger, or even at the current age, for me, the issue comes down to, is it a problem to them? Is this in the context of there being a problem that is impairing their life in some way? The chances are, because it's arisen in a therapy session, it will have a problematic effect. In which case, I would just pick one of those at a time and work with it. Which one would I work with first? Probably the one that seems to have the strongest impact. I don't know. David Grove posited that when somebody spoke like that, there's multiple I's in operation, but the first two didn't connect with anything. The third one connected. And so the first two might be worth exploring. His work, I mean, this was pronoun elicitation that went over 2 days. I mean, in IEMT, we just do it in just a few minutes. So we would really need to get much more into the Grovian approach for getting into those pronoun things. I personally don't do that. It's not the work that interests me, but it's something that you may want to pursue. Have a look at Grove's work, and then into things like clean language as well. That will give you some greater understanding with that. But when we have multiple I's, multiple selves, I start with the one that's the most problematic, because sometimes dealing with the strongest negative impacts positively on some of the others. I'm in conflict with myself. Think about that. If I am in conflict with myself, I'm not expressing myself in the way that I would like, or self-expression takes on a life of its own, independent of I. And so myself, I'd like to beat myself up. I don't like myself, because what I is observing from self-expression is contradictory to what I would like. I do wonder if self-expression and I might have to do with left and right hemispheres. I'm not going to go into that in this particular video, but I can do one explaining that if people are interested. And also executive function, so frontal lobe stuff, going to be very, very much I. Then we have also interplay with limbic system, and then how we actually express things through the sensory motor cortex. But I will save that for another day. So I think that's all I'm going to do for Q&A for this one. I think I've talked quite long enough. I will do another one of these in about a month's time. If you have any interesting questions, do please email them over, message me on Facebook or whatever, or please use the comment section below. I would be delighted if you could click the like button. It really helps me with my YouTube channel, get IEMT better known, gets boosted up the ratings, and so forth. So thank you so much for watching this video all the way to the end. I honor and salute you. Have a good day.